Good morning. I'm glad that Matt Factor's here, and I'll ask him to pipe in if he has any new updates on this as well. So, I've been working with the Alliance Operative Standards Committee for now almost like a decade. And we started this project with writing standards for how various forms of cancer operations should be done, or to at least set minimum standards. The initial scope of the project through the Alliance was to set up standards across different disease sites so that surgical-based studies through the Alliance would follow these minimum standards. And the other point of the committee was that they would vet any surgical trials to make sure that they met minimal opera standards. Since then, it has morphed quite a bit. Approximately 3 years ago, we started discussions with the Commission on Cancer of incorporating the standards set in this book into some of the COC metrics for quality. Just as a quick update on the Operative Standards Manual, the second edition, we're waiting galley proofs on. The second edition incorporates esophageal cancer, and I think there are a lot of people in the audience who contributed to that, and thank you all for your work. In addition to esophageal cancer, there is gastric cancer, rectal, what else did we have? Thyroid, thank you. Papillary thyroid, as well as melanoma. We're currently working on setting up groups for the third volume, which will have one of the GU sites, hepatobiliary neuroendocrine tumors of the abdomen, and I've forgotten the other couple. There are things far removed from thoracic surgery. So at least what we wrote for the operative standards in the first edition for lung is now 8 to 9 years old. The standards and what we wrote still hold, but now we're having active conversations with the Commission on Cancer of incorporating what is in that manual for metrics. Currently, there are three metrics that the COC uses. They have accountability metrics, quality improvement metrics, and surveillance metrics. The surveillance metrics I'll draw your attention to. These are ones with limited evidence that support the measure, and it's used for information to help the programs evaluate their own standards. These are not going to be publicly reported. For lung, there are only three metrics that surveyors currently report on. The bottom two are quality improvement, and these are what are publicly reported. And they are: surgery is not the first course of treatment for clinical N2 disease, and then that systemic chemotherapy is administered within 4 months to day of surgery. But in terms of surveillance metrics, they currently look at 10 regional lymph nodes. And I know we've talked about this in this forum before, of how this may not be the best metric to define quality surgery. In fact, looking at the COC data, only 40% of centers were able to comply with this. And there are a lot of reasons for this. I think most people in the audience, we look at lymph node numbers for lung cancer more as a metric to deal with the COC, and most of us deal with lymph node stations instead. And the basis for the recommendation was based on one poster presentation and one paper, both out of the SEER registry and the NCDB database. Unfortunately, the NCDB and the SEER, they do not collect data on number of lymph node stations or what were assessed, only on number. Even in the major paper to support the COC's surveillance metric, the authors even note that nodal tissue rarely is extracted completely intact, comes out in fragments, and there are all sorts of issues with counting number of lymph nodes. So what we wrote in the Operative Standards Manual was this recommendation, that at the time of resection on the right side, sampled or dissected nodes, and we have a detailed discussion on the merits of dissection versus sampling. On the right side, these are the evaluable nodal stations. On the left, these are the evaluable stations. And in fact, in the synoptic that we presented at the back of the chapter, we suggested that people who are interested in reporting data and trying to keep track of what was actually done for nodal staging, just keep track of this data. So we submitted this to the COC 2.5 years ago, and it basically sat in a committee. And now what the COC is interested in doing is when they do site reviews, and they would have a person actually do chart checks. Again, none of this information is going to be put into the NCDB database. They haven't, even with the latest edition, they haven't changed the number of fields that they would need to incorporate all of that data. So what we recommended 3 years ago and reiterated to the COC was at the time of review of final tumor staging for right-sided tumors include all these various stations. And the basis of this is to account for preoperative staging, including mediastinoscopy, EBIS, and intraoperative staging. This is similar to the S100 trial that Ray O is putting together that Wayne alluded to earlier. It's the same exact idea. So I was going to solicit help from anyone who is interested as we wordsmith this recommendation to the COC. What it'll mean for all of us in this audience is that in your operative reports, if you look at a nodal station and don't find disease, at least indicate that you looked at station 9 or station 8, because you'd get credit for assessing that nodal station. This is more of, you don't necessarily need to change your practice, you just have to be more compulsive in documentation of what was staged. So I don't think I think it forces everyone to pay attention to this, and that's minimum standard for lung cancer operations.
And did you get a response yet from the COC?
So they are excited about this. And 2 conference calls ago, they wanted to go ahead and pursue this, and we're still at the talking back and forth phase. Mm-hmm. Again, this is not going to be publicly reported, and this is only meant for on-site reviewers, like if they open up 10 charts on patients who've had lung cancer operation. This is what they would like to look at.
Mm-hmm. Long line, as expected.
Hi there, Rose Gannam. So I was trained with a rather aggressive cervical mediastinoscopy, and so it's become my habit to count lymph nodes as separate from fragments and report that in the pathology report and my operative reports. And I'm wondering if there is a place for that in your guidelines for including the sum total of mediastinoscopy plus resection for your lymph node number count.
In our entire manual, we stayed away from lymph node numbers entirely.
Understood.
Yeah. So we focused more on stations and completeness.
Okay. And I also wonder about, I was also, it's in my habit to studiously look for level 11 and historical importance of the interlobar lymph node station, and I wonder what the data is behind seeming to leave that out of this.
So in our staging manual, we were looking to make sure that we were dealing with more N2 disease than anything else. So we left that out, and we just had Hylar. And part of this was based on, I always forget the Z's, Z40. So basically following that in what the European societies had come up with, trying to amalgamate all of those practice patterns. But
great. I just have 2 comments. I was just reviewing Rayo's R01 submission, and the NCDB data shows that there's between 40 and 60% of the cases that are done in the U.S. don't have any mediastinal nodes resected. I'm also in charge of taking care of some of the quality issues around our physician network, and I read the op notes from outside. And I think that we need to do a little bit better than just saying that level 7 lymph nodes were looked for. Level 7 lymph nodes are always there. It's very common that someone's doing a left-sided lesion and says, we looked for level 7 and they weren't there. Yeah. They're always there. It's just a matter of whether you go to get them. So in some cases, as you said, maybe level 8s were looked for weren't there, but critical levels should always be taken. And level 4s, level 2s on right, level 7s, The other comment that I have is with the pathology. Frequently, the surgeon does the lymph node dissection and sends the lobe off, but the pathologist doesn't do their job to look for the hilar nodes. So this is a two-tiered requirement that the surgeons has to do their job, the pathologist has to dissect into the lobe and comment on the level 12 through 14 nodes. And so I think that's critical as well.
All really good points. In fact, a big chunk of the book, we took intraoperative photos from thoracoscopic nodal dissections, and this is the one part of the chapter that almost serves like an atlas of defining stations. And Linda was talking about putting a concept together of a study of showing surgeons various anatomical sites and asking them to identify what station is this, as a correlative thing to look at what our operative standards are and if people are able to understand them.
Thanks. Just to echo that point, the pathologist, we went through this exact process about 4 years ago, and now our pathologists do a phenomenal job of dissecting. We get 15, 20 lymph nodes for lobectomy. Where we run into trouble is if we do a wedge resection, and then you sample the appropriate lymph nodes, but they say, well, 3 lymph nodes were sampled. And the COC then, because they're fixated on numbers, says inadequate.
Right.
So I'm happy you're getting
yeah.
away from the numbers.
Right.
Just to harp on the people who aren't here, the pathologists, so they can't defend themselves. So two anecdotes. One is one of my partners did an esophagectomy and he got back a path report that said no lymph nodes. It was like T2 and X, no lymph nodes. And he called up the pathologist and said, that's ridiculous. There was a bunch of lymph nodes in there. Go find them. And then the path report came back and it was 16 negative lymph nodes were present. So that was one observation. Another, I had a patient where I was really focused on doing a pretty thorough dissection. I got 56 lymph nodes on an esophagectomy, and I went back to pathology. I said, who did the grossing on this? I really want to thank them. I want to congratulate them. And it turned out it was a tech, not a physician, not a resident, and it was a tech. And I think they just sort of said, find all the lymph nodes in this specimen, and they wanted to just keep them busy for a little bit. And it was at that point that was the high water mark of my entire career in lymph nodes, thanks to this tech. So that's it. I've been trying to come up with a trial locally, and all my partners just kind of look the other way and ignore me when I say it. But I think that the intervention should be you do your lung operation or your esophagectomy, whatever, and the intervention is you put a sticker on the pathology report. And half the patients get a sticker that says, this patient is on a clinical trial, and it is of the utmost importance that we have the most accurate lymph node count possible. And then the other is just the same, whatever the circulator writes on the path report, esophageal cancer or lung cancer, check it out. And I just bet you, that there'd be a 50% increase in the lymph node count with all else being equal, just by saying, please pay attention to this and give it your best shot. But the whole issue of number of lymph nodes, there's people who talk about weighing the lymph nodes, like do grams of lymph node tissue, because that's an objective thing, and it's not something you can't take a lymph node and cut it in half and call it 2 lymph nodes and get away with it, because it would still weigh the same thing. It's a tough problem. But I think any of these things, the Ray O thing, or having a target to aim for, it just kind of brings it to attention. It makes it part of the conversation in the operating room, and so we all kind of then change our behavior slightly in the right direction.
My pulmonary colleagues participate in a lot of the EBUS as well, and sharing some of this data and some of these recommendations has changed the quality of their reports as well. They're far more meticulous in evaluating stations and providing ultrasound images of what they can and cannot biopsy. So it's had other beneficial effects. Rich?
I was just going to comment for Rose's comment. Felix Fernandez and I wrote, I think, the chapter on this 7, 8 years ago, and we really focused just on lobectomy. I think in the next version, if we talk more about segmentectomy, I think adding in station 11 nodes or station 12 is perfectly reasonable. But at this time, we felt that, or when we wrote that, we felt that the station 11 and station 12 nodes would come out with the specimen. Having said that, personally, we all struggle. Our group struggles, I think, too, in terms of pathology necessarily evaluating those lymph nodes. I was just going to ask for either Matt or Nirmal, for the COC, is pathology at all involved in that, or how can we take back to our institution these recommendations, and what are your thoughts on that?
Matt, if you want to field that one. So the conversation we've had to date, we haven't included pathology.
Just let me speak on the pathology thing real quick, and then I'll let Bryce answer his question, then I can kind of wrap up a little bit. Just speaking on behalf of the COC, I chair the Quality Integration Committee, so now oversee the NCDB. And again, I'll circle back to that in just a moment, but we do have pathologists, so the CAP, College of American Pathology, is represented at the COC, and we're doing a more active job getting all the variety of specialists involved on measures so that they make sense from a variety of perspectives. I wasn't sure what your question was going to be, but go ahead, yeah.
Normal, a couple of things. So if a pathologist does or a thoracic surgeon does an EBUS, does that count towards this?
So as I was presenting this, I wanted to be as inclusive as possible, just make sure things got staged. So when we drafted this 3 years ago for the COC, the goal was incorporate all elements of staging, be it EBUS or mediastinoscopy, because sometimes, for example, on left-sided resection, the 4 Ls you don't necessarily go back and try and find for a left upper lobectomy, but that doesn't mean you didn't look at the 4 Ls.
Right.
It was just a different procedure. So again, as I wrote in italics, this recommendation takes into account the role of preoperative staging, including all modalities.
So do we have a definition of adequacy of sampling, like specifically with EBUS?
It's in the standards.
Okay.
Because
that's a big issue, like with all the different people doing
Yeah.
EBUS.
And we had a whole chapter written on when you need to do something more invasive or when a EBUS is considered inadequate. But at least for this aspect of the work, I needed to give the COC 1 or 2 metrics that they could use that could be broadly applied. And I didn't want to go into the weeds of specifics of EBUS or something else. It just becomes a little too much for a single reviewer, and then it's also difficult to apply it across the board, even into community practices and such.
So
trying to keep it simple.
is there hope for getting away from this 10 number that
Yes.
I think most of us are not too thrilled with?
Yeah, I think this is the first step.
And then the last thing is, sure, more nodes always seem like a good thing, but to be honest, if I'm doing a right upper lobe, I don't typically take down the ligament anymore or dig out station 9 or 8. Are we, as a group, thinking that we should always be doing that for every lobe? Or?
So we went around and around on that because there are enough papers on selective nodal dissection. So kind of mimicking what the European Society, the NCCN, and the other guidelines that we have, we thought this was at least reasonable. So that's why we went with it. So this was at least a group consensus of the 20-some people writing this.
Is everybody doing that? I mean, am I going to be the only one that looks deficient if I? Are you taking down the ligament every right upper lobe? And you do? Okay.
I'll be right there with you, Russ.
Okay. Okay. I mean, it seems like it's a balancing act, and
Sure.
obviously I want to get nodes, and it's not even so much expediency. It's just the more you do, the more
Sure.
It does, as Z30 showed, it does kind of depend on the size of the tumor. So if you have a small stage 1 tumor, you probably don't need to do all the full dissection. But if you have a big tumor, you probably ought to take down 8 or 9, I would think.
Again, the goal of this was not to be so punitive as to at least raise awareness and not get in a situation where there's no assessment either in documentation or simply in paying attention to it.
So Norma, I'm glad you brought this up because I think this kind of got lost on the NCDB side, and I'll definitely take this back. The big problem that we're having right now at the COC is that they're converting over the computer system, which ultimately is a good thing, not a problem. But if anybody uses the SSR, the American College, your personal case log, you've just seen the upgrade, the transition, I don't know, 5 months ago, 6 months ago, or something like that. So the whole college is moving to a company. It was called Quintiles, and I guess they've recently changed to IQVIA, or there's some other way to pronounce it. Anyway, so that all of the American College of Surgeons computer databases and such are going to be on one platform. So where I'm going with that is that we're not allowed to really make any new measures right now. Now, I'm exaggerating, but like 1 or 2, maybe 3 a year. So we're trying to prioritize like the ones that make the most difference and whatnot. And so since I took over the quality committee, it's like I can't get anything done because of being hamstrung by that. But again, in the end, it's a good thing ultimately. Right. So and then just to remind everybody, the 10 lymph nodes which preceded me, it's just a surveillance measure. So just kind of see what's out there. And shockingly, you already mentioned the stats on how few come close to 10. But anyway, I think this is a very, very good idea. We don't want to, overburden the cancer registrars, of course. It would be neat to have the COC fields the same as the STS fields, and the new, version 2.4 of STS comes out, starts this July or whatever, so we should look at that. Because even this level of detail is not in the STS data collection form.
So at our institution, the way we've addressed this is we have a standardized policy that all pathology ends up being reviewed in our tumor board. So our tumor board synoptic that one of the nurses enters for staging, she automatically incorporates all of this. So there's going to be one place for a reviewer to look at, and we also go back in that as a quality metric. So it's doable. I think the solution to documenting it's going to differ by institution. But anyway, that's what we've done. Phil?
Yeah, hi, Philip Linden. So I have a couple comments. First of all, there's no room here for, as we talked about before, tailoring the lymph node dissection to the patient, the tumor size, tumor location, which we know is very important for every patient. If you're doing a wedge resection, someone with severe emphysema, and I know level 11 lymph nodes are not documented here, but you do 11 lymph node dissection of that patient, the risk of the operation air leak is going to go way up. And the surgeon has to weigh that. And likewise, inferior ligament nodes for upper lobe tumors probably don't make sense the majority of the time. So to try to institute this as a widespread standard level of care is still problematic, even though I think it's better than lymph node number for sure. I still have problems with that. And is it the best standard of quality that we want to impose? And I laud the fact that it's not publicly reported because we're not there yet. But even within the institutions, at least our institution, on a monthly basis, we go over in our disease team leader meetings, quality of cares by every disease group. And at every meeting, we are not at the high level of number of lymph nodes, and that's pointed out. So that puts pressure on surgeons and groups to meet those criteria, which to date have not made sense to me. So, and this is going, even though it's not publicly reported, is going to impose pressure to meet these endpoints. And is that really the endpoint that we want to impose for quality of thoracic surgery? It's still problematic in my mind.
I'm just wondering on the left-sided tumors on patients that have clinical N0 disease, how many people in the room are routinely doing either mediastinoscopies or EBUSs to get those L2 and L4 nodes? And would we be dinged if we didn't get the L2 and L4 nodes on the left side?
But then again, in our chapter, we talk about indications for mediastinoscopy. We get into the a T1 clinical T1N0 that you don't necessarily need to do mediastinoscopy and such. So unfortunately for a surveyor, you can't put every single one of those metrics in terms of your decision tree. So at least for the L4 and L2, we even had the if accessible. So we put that little clause in there, at least for the left-sided lesion. So we tried to think about at least the left paratracheal. And in the draft I submitted, I didn't change the wording of that.
Two questions. One, could you elaborate on what to do if you look and you didn't see a node there? I'm not talking about level 7, but AP window node or level 8 node.
I just document it. I just put it right in the operative note. That's the way I handle it. It's probably similar to what Rayo's protocol is. If you're supposed to fill that little sample bucket and you don't have anything there, you still get credit probably from looking at it. On one of the earlier protocols, that's what they were doing.
And to echo what Dr. Linden said, one of the downsides of a wedge is you don't get a lymphadenectomy, and there's a reason you're doing a wedge.
Sure.
You don't want to be there a long time. Should that be held out as a separate thing? I mean, I might pluck some, 10 nodes, but certainly wouldn't want to go in the fissure, and certainly don't want to spend a lot of time doing a level 4 and 7 lymph node dissection. Should it be held out because we know we're doing a lower standard of a cancer operation?
So as I go through this is in the preliminary, the COC has interest, they want to incorporate. I'm soliciting volunteers to help me come up with something reasonable for wordsmithing and that I think is a reasonable metric to send. So, Scott, I'm going to include you on the email chain. So,
That's the risk of standing
but in all
up, right?
seriousness, if anyone is interested in helping, my last name's not the easiest to spell, but that's my cell phone number. So please just give me a call. Matt, do you know? This is the second volume. We're expecting galley proofs, but the first volume had lung and three other disease sites. We have not updated that. So each version that's coming out has new disease sites, and we're currently working on a plan of updating previous disease sites. We have a few logistical problems with the publisher, and we're trying to make a lot of this available online. So that's at the alliance level, along with the publishers, trying to figure out how to best do this.
Well, why don't we?